Thank you for inviting me. My name is Michiel Rienstra. I'm professor in clinical cardiology at the University Medical Center Groningen in the Netherlands. And I was the co-PI of the RACE-3 trial.
So thank you for inviting me. My name is Bao-Oanh. I am a medical doctor and I'm doing my PhD at the Cardiology Department of the University Medical Center in Groningen under supervision of Professor Isabel van Gelder and Professor Michiel Rienstra. And I'm also coordinator of the RACE-3 study.
Well, we know from clinical practice and from research that atrial fibrillation, especially in combination with heart failure, is associated with an increased cardiovascular morbidity and mortality. And we also know that sinus rhythm maintenance in patients with atrial fibrillation is difficult, and it's difficult to improve prognosis in this patient group. So what we try to do is treat the atrial remodeling as good as we can with medication, together with treating the underlying cardiovascular conditions or risk factors in order to attempt to improve the sinus rhythm maintenance and the AF-associated complications of atrial fibrillation. That's why we started the RACE-3 trial. The RACE-3 stands for the routine versus aggressive risk factor driven upstream rhythm control for prevention of early atrial fibrillation and heart failure. And it aims to study the long-term effects. That's what we recently presented at EHRA.
So the RACE-3 study was an investigated, initiated, prospective, randomized, multi-center, open-label, blinded endpoint trial, which was conducted in 14 centers in the Netherlands and in 3 centers of the UK. And patients were included between 2009 and 2015, where the main inclusion criteria were early symptomatic persistent atrial fibrillation and early stable mild to moderate heart failure. So after providing informed consent, patients were randomized to targeted therapy of the underlying conditions or conventional therapy. And all patients in the whole RACE-3 study received treatment according to the AF and heart failure guidelines, and also rhythm control therapy, and all patients underwent an electrocardioversion 3 weeks after inclusion. After that, the targeted therapy group received 4 therapies. So ACE inhibitors and angiotensin receptor blockers, statins, MRAs, and cardiac rehabilitation. And the last included physical activity, dietary restrictions, and counseling. And after 1 year of follow-up, all patients were asked for consent for long-term follow-up, and participating patients in the long-term follow-up in the conventional group were seen every year. And the targeted therapy patients were seen every 6 months, alternating with counseling by phone by a nurse every other 6 months. The total follow-up was 5 years, and the primary endpoint was sinus rhythm at 5 years follow-up. And the secondary endpoint was the composite of cardiovascular morbidity and mortality at 5 years.
So the main results we presented at EHRA are the 5-year results. A few years ago, we already presented the 1-year results. At 1 year, we found that with targeted therapies, as Bao-Oanh just described, we were able to maintain more patients in sinus rhythm. Now we presented the 5 years data, and we found that there was no statistically significant differences regarding maintenance of sinus rhythm in both groups. It was in the targeted arm 46%, and it was 39% in a conventional arm. In addition, we saw as secondary endpoint, we saw a low rate of cardiovascular endpoints during the 5 years of follow-up. It was only 16%, and there were no differences between the targeted group and a conventional group. So unfortunately, the study results at 5 years of follow-up were neutral. And this shows us that in a randomized controlled setting, because that was what RACE3 was, with very strict follow-up protocol, targeted treatment or risk factor management remains complex. And it tells us a lot about the number of cardiovascular conditions we need to consider being treated, how the intensity of treatment of these cardiovascular risk factors should be, and also about the persistence of treatment, because this is a very long-term follow-up study in the cardiovascular field, and outcomes changed between 1 and 5 years.
Yes, so as Professor Rienstra just told us, there were no differences between the groups in sinus rhythm maintenance. However, the topic is still of interest because as you can see that with our study, still we find that rhythm control is difficult. And even with the introduction of ablation, long-term maintenance of sinus rhythm remains cumbersome. So what we need is to be better informed in how to perform targeted treatment. And also we need to know when to target these treatments, these underlying conditions. So we probably need to treat all the cardiovascular conditions at the same time. It's still unknown how to do this optimally. So we need to study this further.
So I think the overall conclusion of RACE3 is that we have shown that in long-term follow-up, that patients with early persistent atrial fibrillation and heart failure did not benefit with regards to maintenance of sinus rhythm, nor cardiovascular morbidity and mortality from the targeted therapies as we applied in RACE3. I think another point that's of importance is that cardiovascular morbidity and mortality was extremely low in this RACE3 trial. And I think that for the future, that rhythm control strategies can be further improved by adding risk factor management of targeted therapies. But how and when and for what duration needs to be further investigated. I think in the latest guidelines, there is already a class 1 recommendation for risk factor management in patients with atrial fibrillation who have an indication for rhythm control therapy. I think that indication stands and will stand in the guidelines. What is needed and also considered at previous EHRA meeting is that we need to do more research on how to do the best risk factor management. And I think in that regard, RACE3 contributed to the evidence.